don't know whether she is. Hi, good evening, everyone. I think there is a marathon session on mechanical ventilation going on this Sunday morning, and I welcome you all. So it's my pleasure to introduce Professor Chiara Robba. She is an associate professor at the University of Genova and a consultant at Polsino San Martino, Italy, currently serving as a chair as a neurointensive care section of ASICM and deputy editor of intensive care medicine. She's a world leading authority on brain lung crosstalk, and we all know that she is presenting on all these forums. Her work focuses on non invasive neuromonitoring, pioneering the use of brain ultrasound and TCD to personalize the respiratory management of brain injured patients. Her elite academic foundation includes a PhD in neurosciences from the University of Genova and a research tenure at Edinburgh's Hospital, University of Cambridge. She has a Google Scholar H index of 72. I think we are good to go, Dr. Tapesh.
Thank you, Dr. Saurabh, for the kind introduction. So, folks, ma'am is, has some issues. She's traveling. She has sent a recording. I will just play the recording and she will try to join for the question answers. That is what she has told us.
University of Geneva, and I will be discussing with you about the mechanical ventilation effects on brain injured patients. I have no conflict of interest for this presentation, so you need to keep in mind when discussing about brain injured patients that every time there is a brain injury, this results in a number of pathophysiological issues which make the peripheral organs more susceptible for complications. So the clotting dysfunction, the inflammatory dysfunction which occurs after brain injury makes more a force hit on the peripheral organs and in particular the lung, which are more keen to develop complications such as pneumonia and ARDS. And this is probably the reason why, if you look at the data on the incidence of ARDS in acute brain injured patients, we see very high numbers because the pooled estimate incidence is around 20%, so it is very, very high. And of course, the occurrence of pulmonary complication is associated with worse mortality and neurological outcome. So in terms of ventilation, what we have learned from the general ICU population is that we need to be protective with the ventilation. In particular, we need to be protective about the plateau pressure and driving pressure, because if we do so, we can potentially have a good effect on hospital mortality. This is what we have learned in both ARDS and non-ARDS patients. But the problem is that the major trials which take in consideration lung protective ventilation strategies have as a criteria of exclusion patients with acute brain injury. In fact, targets and ventilatory settings apparently and traditionally are different in these two populations. And this is why these patients were excluded from the main large studies on this topic. Many reasons are pathophysiological, because every time there is a brain swelling, this results in a compression of the venulus and the venous sinus. So if we do anything which can increase the cervical, thoracic and abdominal pressure, this will result in a reduction of the venous outflow. At the same time, if we manipulate the intrathoracic pressure, this may have a hemodynamic effect, and as a result of this, we may have a reduction of the CPP. The third point is that if you look at the guidelines for a general ICU population, CO2 is allowed to go up as long as the pH is maintained. But of course, this in brain injured patient is a problem because CO2 changes are related to vasodilation and vasoconstriction. So an increase of the CO2 can cause vasodilation, increase of the cerebral volume, and increase of intracranial pressure. So because of all these factors, we really do have very few evidence on this topic. What we do have are, for instance, physiological studies. This is an example. It was 2021 with my group. We did CT segmentation at two different levels of PEEP. And according to the recruitment ratio, we evaluated the association with intracranial pressure. The result of this physiological study are that as long as the alveolar recruitment is good, is appropriate, and therefore does not affect the respiratory mechanics or can even improve the respiratory mechanics without affecting CO2 and MAP, the effect on ICP is minimal, or in some cases it's even improved. Of course, it's very important to be gentle in the modification of the mechanical ventilation setting. This is an interventional randomized trial where different levels of tidal volume and PEEP were applied in brain injured patients. As you can see here in blue and in light blue, the changes of PEEP and tidal volume from low to high PEEP, low to high tidal volume were very quick and very sudden. As a result of this, there is, you see in white, an increase of the ICP when there is a change in the ventilatory settings, but which then tends to be back at the physiological ranges. So be physiologic even when you set the ventilatory settings. Other types of evidence that we have are post-hoc analysis of large databases. This is a post-hoc analysis of the ENIO trial, where as primary outcome was evaluated the effect of ventilatory setting and in particular mechanical power on hospital mortality, reintubation and tracheostomy, and there was a signal towards an association between the use of low mechanical power and improved hospital mortality, reduced risk of intubation, reduced risk of pulmonary complication and need of tracheostomy. So similar to what happens in the general ICU population. Going up with the level of evidence, we have pre-planned secondary analysis. This is the TTM2 study, so post-anoxic brain injured patients. Even in these cases, association with ventilatory settings and outcome. And what was found was not really a clear association between the single ventilatory setting, so it's probably not just one parameter which may affect the outcome of the patient, but the combination of these. In particular, when we take in consideration strongest predictors such as the plateau pressure and the respiratory rate, which probably are responsible for the work that is given to the lung. We have a randomized control trial. This trial was published two years ago. The two arms were conventional strategy, which was considered at 8 ml per kilo predicted body weight, so targeted on volume and PEEP, 4 of PEEP versus 6 ml per kilo predicted body weight with a PEEP of 8. No effect on the outcome was evaluated according to the two different strategies, but looking at the data of this randomized control trial, the problem is not really the difference in tidal volume, but there was no difference in driving pressure and plateau pressure. Therefore means that these two strategies probably were both protective in terms of lung protective ventilation. Meta-analysis, at least until some years ago, are not really consistent. There is a signal versus being in favor of the studies for mechanical ventilation, lung protective strategies, but was not significant. The other type of information that we have is about clinical practice. This is the Ventilo survey. Edoardo Piccetti in 2020 did an international survey through the European Society of Intensive Care Medicine, and what he found out is that clinicians are not scared anymore to put high level of PEEP or low tidal volumes if the patient requires it from a lung perspective. So they are not so scared anymore about the potential physiological effect on the brain. And the concept of lung protective ventilation seems to be applied even in this population. And this is also what has been demonstrated in an observational study, the Ierina et al., 3 different large databases from 2004, 2010, and 2016. As you can see, there is a clear reduction in the mean values of tidal volume. In 2004, a huge number of patients were ventilated with more than 10 ml of predicted body weight. In 2016, only a minority. And the same for the PEEP, as in 2004, the median value of PEEP was 4, and 1/3 of these patients were ventilated with ZIP, whereas in 2016, only a minority of these patients were ventilated with a zip. Other type of evidence are the guidelines, but I have to acknowledge that these guidelines are based on a very, very low level of big studies, no randomized controlled trial, observational studies with huge heterogeneity and huge limitations. However, using a Delphi approach, the expert basically agreed on the fact that lung protective strategies should be used in brain injured patients, especially in those without a clinically significant ICP elevation. No consensus was found in case of patients with ICP which is unstable. PEEP levels should be adopted with the same levels that are used in patients without brain injury. And this was a sort of weak agreement. And the levels of zip should be absolutely avoided in brain injured patients. What we did is therefore to perform a multi-center observational study, which is the Ventibrain study, which is specifically focused on mechanical ventilation in acute brain injured patients. 74 ICUs in 26 countries were included. Patients with acute brain injury requiring ICU admission and invasive mechanical ventilation, and data were assessed in terms of the mechanical ventilation settings in the first week every day, and then on day 10 and on day 14. This is the flow chart of the study and the characteristics. So 95 patients were included, 66% were male, median age 58. Many of these patients from low-income countries, many of these patients with problems of intracranial pressure, and these are basically the results. Each part of this is the description of the ventilatory settings in the different days. And as you can see, there is a clear use of lung protective ventilation strategies with a tidal volume medium of 6.5 ml per kilo predicted body weight. So very, very protective. And if you look at also the peak, the peak plateau, and the driving pressure and the mechanical power, even in this case, there is a clear use of lung protective ventilation strategy. The other aim was to assess whether these strategies would change according to the presence or not of increased ICP. So in green, patients with increased ICP, and in blue without increased ICP, no difference were found in terms of ventilatory settings across the different days. One of the other outcomes was the assessment of heterogeneity across different countries for the different ventilatory settings, and we found a high country-to-country variability, especially for PEEP, driving pressure, respiratory rate, less variability for plateau pressure and tidal volume. And finally, the outcome, which is the association with mortality and neurological outcome, are presented here. We found a significant association between the peak plateau driving pressure with outcome, a U-shaped curve for what concerns the FiO2, the oxygenation, the carbon dioxide, and an inverse correlation which might at the first look seem surprising for what concerns tidal volume of predicted body weight. For 6 months neurological outcome, the only factor associated with neurological outcome was the FiO2, no other parameters. So, what I have learned from this study and from the previous literature, I have learned that lung protective strategies are very, very often used in this population, regardless of the presence of increased ICP. So this means that in this population, ICP is more often controlled with other strategies rather than the ventilation and the CO2. I've learned that there is a huge variability across different countries, but not especially for parameters like mechanical power and driving pressure. So probably we should increase the knowledge on this parameter. And I've learned that there are some modifiable factors, which are the ventilatory settings, which can be associated with mortality and eventually neurological outcome. So in these settings, it's important to be protective for what concerns the pressures. We need to individualize the PEEP, the respiratory rate, the FiO2, the carbon dioxide, but probably we should not be too protective regarding the tidal volume, because as I showed you before, the association is inverse. So my opinion is that as long as the plateau pressure, the driving pressure are protective, probably we can use higher tidal volume, because especially in this population, this can really help to manage the carbon dioxide. So at the end of the story, who is the winner between the brain and the lung? In brain conditions which are stable, the lungs wins, so we just follow the guidelines, escalating strategies for the management of lung injury and pulmonary complications. On the other side, if we have a healthy lung, but we have problem with intracranial hypertension, we probably need to use the staircase approach of ICP, with the risk of having pulmonary complications, but in this case, the brain wins. The problem is when there is a concomitance between increased ACP and pulmonary complication.
ACP and pulmonary complication. In this case, things becomes much more difficult, and instead of two staircase approach, what can become is something similar to this, where you have different steps according to the tiers, so according to the difficulties in managing intracranial pressure, and according to the severity of ARDS. The general concept is that in this case, you need to be ready to skip some steps of your treatment for one organ or one other organ, but you have two organs that need to be protected. So these are basically my conclusion. I think that in terms of protective strategies, we have shifted a bit from the concept of recruitment maneuver, PEEP, etc., to a concept which in the guideline is described as tidal volume of predicted body weight, which probably should be more shifted and considered in terms of the pressure that is related to the use of different tidal volume. And with this, I thank you for your attention, and I am available for any question.
Dr. Tapesh, is Dr. Chiara available?
Just let me check. Dr. Robba ma'am, are you there? Let me check in the participants.
I'm not able to see her name out here.
Yeah, she is not there. So
The last two slides actually were not visible, Dr. Tapesh.
actually, yeah, there was a problem. Something happened. So we will put up the recording, Dr. Lalit. You can see it, because now it'll be difficult to share and everything and get to the real slide because the recording. So if anybody has any questions, please feel free. We will try to answer, or any comments to make.
Doctor, it's only about the last few slides which were not there. There is
Yeah,
no
actually
question
something
as
happened to the something funny happened.
See, Dr. Chiara Robba was the main chief investigator and the principal investigator in the Ventibrain study, which is the main study which actually now have shifted the focus from the field of guessworks towards the data-driven approach, I will say. So it successfully generated the hypothesis related to the future randomized control trial, I will say, specifically regarding whether the targeted reductions in the driving pressure and optimized PEEP and mechanical power can directly improve the long-term neurological recovery in acute brain injury patients. But one important thing which has been driven from the Prolabi studies, Ventibrain studies, and everything, that apart from doing a regular neuromonitoring in these patients, whether the ICP is raised or not, the important thing is that low is not always better. So, in a brain injured patient, so if your plateau pressure and the driving pressures are in a good range, you can have a tidal volume so that the CO2 should kept in check in these patients. So that's, I think, the main takeaway as of now from these studies.
Okay, thank you, Dr. Saurabh, for your comments. There are no questions, so we shall close the session and we shall wait for the next session. Thank you very much.
Yeah. Okay.